Dear colleagues, this presentation is dedicated to examination of cardiovascular system. Presentation was made by the staff of the Department of Propedeutics of Internal Medicine number 1, Head of Department, correspondent member of the Academy of Medical Science, Professor Netyazenko Vasil Zakharovich. Inspection of neck. Inspection of neck is very important for cardiovascular system examination. During inspection of neck, we have to evaluate presence or absence of abnormal arterial carotid pulsation, which is called by Latin terminology saltus carotis. This pathological symptom we can observe in patients with aortic regurgitation. For revealing this pathological symptom, we ask patient to turn his head to the left, then to the right. Our conclusion that pathological arterial carotid pulsation is absent. Then we evaluate presence of neck veins swelling. In a healthy person, in a horizontal position, it's possible to see low third part of the neck vein. In a vertical position, this vein is invisible. In our patient, neck vein swelling is absent. Stokes color is also absent. Then we have to make inspection of the heart region. During heart region examination, we evaluate presence of cardiac hump. Formates in the childhood due to heart diseases with heart chambers enlargement. These enlarged chambers pressed on ribs and caused their deformation. In our patient, cardiac hump is not determined. Also, we evaluate presence of varicose veins in a region of manubrium sterni. In our patient, this pathological symptom is not determined. Then we have to continue our inspection in the heart apex region. In the heart apex area, pulsation is not determined. As a variant of norm, slight pulsation in this region may be visible. Then, by the clockwise, we continue our inspection in the left costal arc region and below xiphoid process. Here we can reveal pathological pulsation, which may be due to the hypertrophy and dilation of the right ventricle and can be considered as a heartbeat, or by Latin terminology ictus cordis. In our patient, this pathological pulsation is not determined. Along the midline, we can see small pulsation, which is intensified on exhalation. This is pulsation of abdominal part of aorta. Then we examine area of right costal arc, where we can reveal pathological liver pulsation, which can be true or transmissive from the heart. Then we move by the clockwise and make inspection of the second intercostal space, where we assess a presence of pathological pulsation. In our patient, this pathological symptom is not determined. After this area, we continue inspection in jugular fossa, where we reveal slight pulsation. Then we make inspection in the left second intercostal space. Pathological pulsation here is not determined. In the area of absolute heart dullness, pathological pulsation is also absent. Pulse examination. Examination of arterial pulse will begin from definition of pulse symmetry on both hands. It's very important to make correct arterial pulse palpation. The thumb should be on ulnar edge of the wrist, other forefinger should be in the sulcus radialis. This is the correct hand's position for pulse examination. Symmetry of pulse we determine by symmetry of pulse feeling at the same time. If pulsus is equal by feeling and the time of occurrence the same, we call this characteristic pulsus equalis. If not, we call it pulsus differens. Other properties of pulse we continue to assess on one hand. If pulse is symmetric, we continue further examination on any hand. If not, we use that hand where other properties of pulse are more pronounced. After we assess equality and symmetry of pulse on both hands. On one hand, we determine rhythm or regularity and frequency of pulse. Regularity of pulse we have to assess first, because if rhythm is regular, we calculate pulse rate for 15 seconds and multiply by 4, or for the 30 seconds and multiply by 2 to recalculate it into a minute. But if rhythm is irregular, we have to calculate pulse rate for whole minute or even for 2 minutes and take an average. Obligatory, we have to remember that properties of arterial wall influence on all other characteristics of arterial pulse. If arterial wall is changed, we have to consider it when assess other characteristics. If arterial wall is unchanged, there will be no differences between arterial wall and surrounding tissue, and will not palpate it properly. If arterial wall has atherosclerotic changes, it becomes thicker and we can palpate it in a wire form. And we are able to differentiate it from the surrounding tissues. For assessment of different properties of arterial wall, the vessel should be empty, without the blood. How to make it? For this pattern, we use third and fourth fingers. By these fingers, we press vessel to the sulcus radialis. We completely press vessel until pulse wave disappearance, and then by index we palpate arterial wall. Please remember that first of all we have to press vessel by third and fourth fingers, and then by index we palpate along the vessel in the sulcus radialis. If it is difficult to make, we can use another hand and palpate by another hand this vessel in a sulcus radialis. If arterial wall is not changed, you will not feel any differences between vessel and surrounding tissue. So our conclusion is absence of atherosclerotic changes of vessel. To assess tension and elasticity of arterial wall, the vessel should be filled by blood. We use special pattern for its assessment. By second and fourth fingers of our hand, we simultaneously compress the vessel and press it to sulcus radialis. By the third finger, we assess elasticity and tension of arterial wall. We can easily palpate it. It's soft and moderately tensed when we touch it. Then we have to assess pulse tension. Pulse tension is a force which we apply to make complete disappearance of a pulse wave in a radial artery. When we press artery and apply moderate force to stop arterial pulsation, we call this tension moderate. In a case when pulse tension is increased, by Latin terminology pulsus durus, we need to apply significant force to stop arterial pulsation. In a case if necessary to apply very low force to stop arterial pulsation, we call this pulse pulsus durus or soft pulse. Assessment of the pulse feeling. For the assessment of the pulse feeling, we completely press radial artery to the sulcus radialis and then slightly relieve and assess the first pulse wave. If vessel dilation when you diminish compression is very high and the pulse wave is big, we call this type of feeling pulsus plenus or full pulse. In a case of moderate vessel dilation, like in our patient, We define this type of feeling like moderate. In a case when we remove vessel compression but arterial dilation in the first pulse wave is very low, we determine this type of feeling as empty pulse or pulsus vacuus by Latin terminology. Then we have to assess the speed and height of the pulse. To assess the speed of pulse, we press arteria to sulcus radialis by third and fourth fingers, then relieve and assess the speed of arteria filling by blood with the second finger. In our patient, the speed of pulse is moderate. In a case when after compression of patient's radial artery by your third and fourth fingers, you assess by your second finger that speed of blood filling of the patient's radial artery is high, you will determine his pulse speed as fast, or by Latin terminology pulsus celer. If by the same action we compress, then relieve patient's radial artery and determine slow speed of blood filling this vessel, we call this type of pulse speed slow pulse, or by Latin terminology pulsus tardus. It's necessary to understand that very frequently slow pulse may be also associated with low feeling of pulse and low height of pulse. Definition of the height of pulse. Height of the pulse we determine as an amplitude of arterial wall fluctuation during its filling of blood. If this fluctuation is high, we determine high pulse, or by Latin terminology pulsus altus. In a case when we determine low amplitude of radial arterial fluctuation, we define this pulse as low pulse, or by Latin terminology pulsus parvus. So, totally, we determined 7 properties of arterial pulse. These are symmetry, regularity, rate, tension, feeling, speed, and height. Eighth property of pulse is pulse uniformity. After compression of the patient's radial artery by our third and fourth fingers, by our index, we assess pulse waves. Are they equal by their characteristics or not? Are they similar each with other or not? If all pulse waves which we palpate are similar, we assess these pulse waves as uniform, or pulsus equabilis. Please don't mix with pulsus equalis. In a situation when pulse waves are not uniform and have different characteristics, we determine this pulse as inequabilis, especially if pulse rhythm is irregular. These changes of pulse can be observed in patients with atrial fibrillation, extrasystole, etc. In a case when pulse wave will not have similar characteristics, but rhythm of pulse is regular, we determine this pulse as pulsus alternans. In our patient, alternation of pulse is not determined. Next characteristic is dicroticity of the pulse. Pulsus dicroticus is a pulse with dicrotic wave appearance in palpation. We can palpate it as a small rise on a descent of the pulse wave. In a healthy person, this rise is absent. In most normal persons, a dicrotic wave is not palpable. The dicrotic pulse has two palpable waves, one in a systole and one in diastole. It occurs most frequently in patients with very low stroke volume, particularly in those with dilated cardiomyopathy. In healthy persons, the dicrotic wave is not palpable. In our patient, pulse dicroticity is not determined. Next characteristic which should be always absent in our patients is lability of the pulse. In a person who is in a lying position and then change position to vertical, normal physiological increasement of pulse is 10-15 beats per minute. If during changing patient's position pulse increasement is more than 20 beats per minute, that pulse we calculate as pulsus labilis. How to determine lability of the pulse? We have to calculate pulse in a patient in a lying position for 15 seconds, then multiply by 4 to recalculate it in a minute. Then we ask our patient to sit and calculate pulse again in a sitting position. Then compare number of the pulse waves in a lying position and in a sitting position. We also can ask patient to stay and calculate his pulse waves in a minute in a standing position. If the difference between pulse waves in a lying position or horizontal position and vertical position will be more than 20, we'll determine this pulse as pulsus labilis. Then we assess paradoxality of the pulse. In a healthy person, we will not determine changes of a pulse feeling during phases of breathing, inhalation and exhalation. In the case of pulsus paradoxalis, pulse will increase in volume on expiration and decrease in volume in inspiration. This type of pulse we will determine in a patients with tense pleural effusion. In this pathological condition, increased intrathoracic pressure will cause diminishment of pulse feeling. So we will determine decreasement of pulse feeling during patient's inhalation. In our patient, we don't determine any significant changes of pulse feeling during inhalation and exhalation, so our patient's pulse is not paradoxalis. The last characteristic which we determine is deficiency of pulse. Deficiency of pulse is the difference between number of heart contractions and number of pulse waves. Deficiency of pulse we determine when number of heart contractions is more than number of pulse waves. This pathological characteristic we can define in a patients with atrial fibrillation, different types of extrasystolia when due to pathological heart contraction, low ejection volume don't reach peripheral vessels. To determine pulse deficiency, we put our phonoendoscope to heart apex region and simultaneously assess heart sounds and appearance of the pulse waves. So we define relationships between heart sounds and appearance of the pulse waves. In a norm, after first heart sound, we can note appearance of the pulse wave. Till the whole minute, we have to assess presence of the pulse wave after each heart contraction. In a case when we auscultate heart sounds but don't feel pulse wave by palpation, we interpret this pathological condition as pulse deficiency. We have to calculate number of missed pulse waves till the whole minute for 60 seconds. For example, if we calculated missing of 5 pulse waves for 60 seconds, we define that pulse deficiency is 5. Palpation of the heart region. We begin palpation of the heart region from the assessment of apex beat characteristics. To assess properties of apex beat, we put our hand in a heart region. First finger should be along the sternum. Second, third, fourth fingers are in intercostal spaces. Third, fourth, fifth intercostal spaces. Then we have gradually pull up our fingers and define the area of maximal pulsation. By this action, we pulling up our fingers and define the area of pulsation. We leave one finger if it is enough to cover all area of pulsation. If not, we can add one more finger. In a norm, square of normal apex beat is 2 square centimeters. Then we have to calculate location of apex beat. We calculate intercostal spaces from Lewis angle, second, third, fourth, fifth. Fifth intercostal space 1.5 centimeters medially from left midclavicular line. Next characteristic, square of apex beat, approximately 2 square centimeters. Next characteristic is height of the apex beat. Height of the apex beat is the amplitude of chest fluctuation during heart contraction. Height of the apex beat may be moderate or normal, high and low. Then we have to assess resistance of the apex beat. Resistance is a force which we can apply to stop fluctuations of the chest wall due to heart contractions. In a norm, resistance is moderate. In a pathological condition, it can be low and high. Next characteristic is strength of the apex beat. Strength of the apex beat is determined by resistance of the heart apex to palpated fingers during systole. So we already determined localization, square, height, resistance and strength of the apex beat. Then we have to determine mobility of the apex beat. Movements of the apex beat during changing of body position. We turn our patient to the left side, leave the middle finger on apex area which we found before, then by fourth finger palpate the new area of apex beat pulsation. Then we ask our patient to turn on his back and assess the distance between middle and fourth fingers. As we can see, distance is approximately 2 cm. Then we ask our patient to turn to the right side, and by the second finger we assess the new position of apex beat, approximately 5 mm. Then we have to assess pathological vibration in the heart region, which we call diastolic cat's paw symptom. In our patient, pathological symptom of diastolic cat's paw vibration is not determined. Percussion of the heart. Determination of heart borders by percussion we have to make in a sequence: right border, then upper, then left border. For determination of the right border of the heart, first we have to determine position of the diaphragm. By the right mid-clavicular line, we make percussion from the clear pulmonary sound to the dullness. When we determine diaphragm level, we move one rib up, but not upper than fourth interspace. Then we turn our finger vertically parallel to the right border of the heart and make percussion. When we reached blunt sound, we put mark from the side of finger which is turned to the clear pulmonary sound and define right border of the heart. In our patient, right border of the heart is 0.5 cm laterally from the right edge of the sternum. Then we have to determine upper border of the heart. For percussion we use left parasternal line and make percussion over the ribs and intercostal spaces. Pay attention for that, because distance between beginning of place of our percussion and upper border of heart is small. Pay attention that we start our percussion immediately below the clavicle. Intensity of percussion should be low. We use so-called quiet percussion. So we define that upper border of the heart by left parasternal line is on a third rib. Then we have to determine left border of the heart. Before percussion of the left border of the heart, we have to assess apex beat location by palpation, because we have to make percussion in that intercostal space where apex beat is found. In a case when impossible to determine apex beat location, for example in obese patients, we determine left border of the heart in a fifth intercostal space. So we define location of apex beat and start our percussion. Determination we have to start from axillary anterior line. We make percussion from clear sound to blunt sound. When we reach this area, we make mark from the side of finger which is turned to clear sound. So left border of the heart is 1.5 cm medially from left midclavicular line. Also, we can determine location of left border of the heart by direct percussion. By direct percussion, we determined the same location of the left heart border. In a case when patient's heart enlarged in a dorsal size, indirect percussion may give us false results. Because when we make percussion by indirect method, our percutory waves spread in the frontal plane. In this case, we have to make so-called ortopercussion. In this type of percussion, our percutory waves will spread in sagittal plane. For this type of percussion, we place our finger pleximeter in a sagittal direction. And then make percutory knocks. Look in comparing indirect percussion and orthosagittal percussion. Orthosagittal percussion led us to define left border of the heart with more accuracy. Let's revise all three methodics. Indirect percussion, direct percussion, Ortopercussion. Auscultation of the heart. Auscultation of the heart, we have to start from the first point of auscultation, which is located in the fifth intercostal space, 1.5 cm medially from left midclavicular line. It's a region of apex beat. First we auscultate during the calm breathing. Then ask our patient to inhale and hold his breathing. Then ask exhale completely and hold his breathing. Then ask turn to the left side. Ask inhale, exhale and hold his breathing. So auscultation in the first point we have to make during calm breathing, complete inhalation, complete exhalation and holding of breathing. Phases of breathing are related to such sound phenomena as splitting and reduplication. By turning to the left side, heart becomes closer to our phonendoscope, and in this position third heart sound is better auscultated. Second point of auscultation is tricuspid valve. We put our phonendoscopes on the base of xiphoid process and make auscultation in a calm breath. And ask inhale and hold breathing, then calm breathing, then complete exhalation and holding of breathing. Third point of auscultation is aortic valve, second intercostal space to the right from the sternum. We auscultate aortic valve during calm breathing and compare its loudness with fourth point of auscultation, which is located on 1.5 cm laterally from the left edge of the sternum in second intercostal space. This is the point of arterial pulmonary auscultation. During this comparing of loudness of sounds over aorta valve and arterial pulmonary valve, we define accent or prevalence of sounds in one of these points. In a norm, loudness of sounds over aorta and over arterial pulmonary valves is equal. In a case of accentuation of second sound over aorta valve, we will determine more loud sound in the second intercostal space right from the sternum. In a case of accentuation of second sound on arterial pulmonary point, loud sound will be over fourth point of auscultation, second intercostal space to the left from the sternum. Then we move our phonendoscopes to aorta valve point and ask our patient to inhale and hold breathing. Then breath calm, then inhale, exhale completely and hold breathing. Also, we can make patterns which help us to define aorta pathology, such as atherosclerosis of aorta. We ask our patient to sit, to move his hands behind his head and slightly move forward. Then ask to inhale, completely exhale and hold his breathing. Then we ask our patient to move forward approximately on 45 degrees, completely inhale, then completely exhale and hold his breathing. If we note appearance or increasing of systolic murmur in these positions, we can interpret it as a clinical sign of atherosclerosis of aorta. Then we will transfer to auscultation of the fourth point, pulmonary arterial valve. We also ask our patient to inhale completely and hold his breathing. Then breathing calmly, then completely inhale, exhale, and hold his breathing. Fifth point of auscultation, or Botkin-Erb's point, is localized in the third-fourth intercostal space near the left edge of the sternum. In this point, we also ask our patient to completely inhale and hold his breathing, then breathing calmly, then completely inhale, completely exhale, and hold his breathing. Then we will make conclusion.